Hello, everyone. Today we will continue with the second part of diseases of the esophagus. So far, we have discussed diseases causing obstruction and vascular diseases and some of the inflammatory disorders of the esophagus. And today we will continue with other inflammatory disorders and tumors. Another type of esophagitis is called reflux esophagitis, or the term gastroesophageal reflux disease GERD. It means reflux of gastric contents to the lower part of the esophagus, and it is the most common cause of esophagitis and the most common complaints by patients visiting the outpatient clinics. The squamous epithelium of the esophagus is sensitive to the acids that are carried in the gastric juices to the lower part of the esophagus upon recurrent reflux of these contents. However, there are some protective forces that can protect the esophagus from this damage by mucin and bicarbonates that are secreted from submucosal glands and by the high lower esophageal sphincter tone, the contraction of which leads to prevention of reflux of gastric acidic contents. Now, the pathogenesis of reflux esophagitis includes decreased lower esophageal sphincter tone or anything that increases the abdominal pressure or some cases that are idiopathic. The causes of decreased lower sphincter tone could be alcohol consumption, smoking, hiatal hernia, or the use of some medications such as CNS depressants. Hiatal hernia means when the part of the stomach herniates through the diaphragm and becomes part of the thoracic cavity. This will lead to a decrease in the tone or the decrease in the tone of the lower esophageal sphincter and reflux of content to the lower esophagus. Causes of increased intracranial pressure includes obesity, pregnancy, delayed gastric emptying, and increased gastric volume. The morphology and the changes that we see of reflux esophagitis includes either macroscopic findings that the doctors see during endoscopy, and that depends on the severity of the reflux. The mucosa could be unremarkable with no changes, or could have simple erythema and redness due to inflammation. Microscopically, the earliest manifestation is the infiltration of the squamous epithelium by eosinophils. Later on, and in more severe cases, we might have neutrophil infiltration accompanied by basal layer hyperplasia of the basal squamous epithelial cells and elongation of lamina propria papillae. If we find two out of these findings on microscopic examination of biopsies taken from the esophagus, we can establish a diagnosis of reflux esophagitis along with the clinical manifestations. This is, as you can see here, is the erythema and the redness of the lower esophagus in patients with reflux esophagitis. And as you can see in the second picture, those cells with the granular eosinophilic cytoplasm are considered the eosinophils, as you can see here. The clinical features of reflux esophagitis, it's usually encountered in patients over 40 years of age, but it can occur in infants and in children. It is presented with heartburn or what we call burning sensation in the epigastric area, along with dysphagia and difficulty in swallowing. Sometimes regurgitation of sour tasting gastric contents even to the mouth in severe cases. Rarely they can present with symptoms that are similar to heart disease or acute myocardial infarction, because some patients can come with severe chest pain that can be mistaken for a cardiac problem, especially when they present to the emergency room. The treatment of reflux esophagitis is by proton pump inhibitors to decrease the acid secretion. The complications, it might be complicated by ulceration of the esophagus, causing peptic ulcerations, hematemesis, which is vomiting of blood, and melena in cases of bleeding that passes through the stomach and altered with the acidity of the stomach, so it will pass to the in the stool as a black colored stools. Sometimes it might be complicated by the stenosis and the strictures in patients with recurrent and long-standing reflux esophagitis because the repair of the inflammation could be by fibrosis, leading to narrowing of the lumen of the esophagus. And the most feared complication is Barrett esophagus, which is intestinal metaplasia in the esophagus that might be a precursor of the esophageal adenocarcinoma. Another type of esophagitis is called eosinophilic esophagitis, and from its name, it is rich in eosinophilic infiltration of the squamous epithelium. It is a chronic immune-mediated disorder. The symptoms are variable. They could present with food impaction and dysphagia in adults. In children, they can present with GERD-like symptoms or present with feeding intolerance and some allergy to certain types of food. It might be encountered in children. Also, even gastroesophageal reflux disease can present in children, and these patients will come to the outpatient clinics as irritable children, recurrent vomiting, and we have at this point to differentiate whether it is a gastroesophageal reflux or an eosinophilic esophagitis. The morphology is somehow different in eosinophilic esophagitis from reflux esophagitis because here in the classical cases, we might see rings in the upper and mid esophagus, while it changes in reflux esophagitis usually affects the lower part of the esophagus. Here we might see numerous eosinophils in the epithelium, while also we can see eosinophils in reflux esophagitis, but the number of eosinophils here is much larger, and they can involve the mid esophagus and the upper esophagus. Far from the gastroesophageal junction. These findings could help us differentiate between reflux and eosinophilic esophagitis because they are treated in different ways. As you can see here, this is from the endoscopic picture. We can see the rings in the esophagus, which can cause the symptoms of dysphagia for the patient and food impaction. And as you can see here, there are a numerous number of eosinophils with eosinophilic granules infiltrating the squamous epithelium. The management, if we establish a diagnosis of eosinophilic esophagitis, most patients are atopic and they are usually associated with the other atopic manifestations like atopic dermatitis and eczema, allergic rhinitis, and asthma. Sometimes they are having peripheral eosinophilia, which is increased number of eosinophils and peripheral blood examination. And upon treatment with proton pump inhibitors, they are refractory to treatment and will not respond. The symptoms will not be alleviated. The treatment for such cases is by dietary restrictions خاصة الدايتس اللي بتعمل symptoms للpatients زي cow's milk خاصة بالأطفال and soy products. So dietary restrictions is of benefit, and sometimes they give them topical or systemic corticosteroid therapy. So PPIs have no value in the treatment of eosinophilic esophagitis. That's why we have to differentiate between them, and the differentiation is not always straightforward. Another disease of the esophagus is the Barrett esophagus. The Barrett esophagus is a complication of long-standing gastroesophageal reflux disease, and it is defined by the presence of intestinal metaplasia in the esophagus, which is the presence of goblet cells. It affects only 10% of individuals with symptomatic long-standing GERD and affects males more frequently than females in the age range of 40 to 60 years. It's important to establish a diagnosis of Barrett esophagus because it is a direct precursor of esophageal adenocarcinoma. The risk of dysplasia when metaplasia occurs is 0.2 to 1% per year. And this dysplasia can be graded as low grade or high grade, and it can be a precursor of adenocarcinoma of the esophagus. The morphology on endoscopy, we might see red tongues extending upward from the gastroesophageal junction, and upon biopsy of these areas, we might see the intestinal metaplasia. It is defined by the presence of goblet cells. We cannot diagnose Barrett esophagus without the presence of intestinal metaplasia. So biopsy is mandatory to establish the diagnosis and to follow up the case for the regression of metaplasia or the development of dysplasia whether low grade or high grade, or the development later on of invasion, which we call it intramucosal carcinoma or early carcinoma. As you can see here, we have the tongues, red tongues extending from the gastroesophageal junction upward. This is the red tongue here. Also, biopsy from these red tongues will highlight the presence of intestinal metaplasia and goblet cells. As you can see here, this is the esophagus. Normally, the esophagus is tan or light pink in color, but as you can see here, it is red and erythematous. And here we can see the goblet cells in the biopsy taken from the esophagus. As you can see here also, here is the squamous epithelium normally found in the esophagus. On the other side, we have those goblet cells that are distended with somehow bluish mucin and hematoxylin and eosin stains. These cells should be found in the intestine and not be found in the esophagus. So when we found them in the esophagus, it means there is an intestinal metaplasia. And it's a progression from a normal squamous epithelium with recurrent or long-standing reflux to Barrett esophagus, then to low-grade dysplasia, then high-grade dysplasia, then invasive adenocarcinoma. The management of Barrett esophagus is by periodic surveillance, endoscopy with biopsy to screen for the development of dysplasia. If high-grade dysplasia or intramucosal carcinoma is developed, this patient needs intervention. And last, we will talk about esophageal tumors, which are divided into squamous cell carcinoma, which is the most common worldwide, and adenocarcinoma, which is on the rise. Nowadays, half of the cases in developed countries are due to adenocarcinoma, and half of the cases are due to squamous cell carcinoma. The adenocarcinoma, as I said before, it develops from Barrett esophagus and long-standing GERD. The risk is greater if documented dysplasia is present, if the patient is a smoker, obese, or have taken radiotherapy before. A male to female ratio is 7:1, so it's very high in males, and there is a geographic and racial variation. It's more common in developed countries. Maybe in developed countries, there is the incidence of obesity is high and association with gastroesophageal reflux disease is high, which will lead to Barrett esophagus and development of adenocarcinoma. The pathogenesis, as I said, it's just as easy as from Barrett to dysplasia to adenocarcinoma by acquisition of genetic and epigenetic changes with the chromosomal abnormalities and P53 gene mutations. But this process is a multi-step process where it is affected by many environmental factors. The morphology of these tumors, they occur in the distal third of the esophagus, which is the site for gastroesophageal reflux disease and reflux esophagitis. Early on, the lesion is just flat or raised patches, but later on it becomes more exophytic and forming a tumor and a mass projecting to the lumen of the esophagus and may cause obstruction of the lumen. And also it will infiltrate the wall of the esophagus upward and downward. Microscopically, these tumors are adenocarcinomas, so they produce a gland and produce a mucin. As you can see here, this is the mass, an exophytic mass, just at the gastroesophageal junction. This is part of the stomach here and part of the esophagus here. And under the microscope, the diagnosis is established as an invasive adenocarcinoma. The clinical features, because it's an exophytic mass, a mass obstructing the lumen of the esophagus, so these patients present with pain and difficulty in swallowing. In advanced cases, they might present with progressive weight loss because of the tumor itself, tumor cachexia, and because of the difficulty in swallowing, so the patient stops eating, chest pain, sometimes vomiting. Advanced stage at diagnosis, this is the most important or most unfortunate feature for these patients because they present late, thinking that their symptoms are related to the reflux. When the disease is diagnosed as at an advanced stage, the 5-year survival is less than 25%. However, if the patient is lucky and we discover the case from Barrett esophagus or dysplasia and follow the patient up upon the development of an early invasive carcinoma, the 5-year survival will be 80%. So the time of presentation and the time of diagnosis is very important. The other type of cancer is called squamous cell carcinoma, male to female ratio. Again, it's higher in males, but here it's 4:1. It's more in low resource countries and underdeveloped countries. The risk factors here is not related to reflux esophagitis. It's mainly due to alcohol, tobacco smoking, poverty, and caustic injury with acids and alkali induced injury, achalasia, which we talked about it earlier, Plummer-Vinson syndrome, which is characterized by iron deficiency anemia, dysphagia, and webs in the esophagus, frequent consumption of hot beverages, and previous radiation therapy. These are called risk factors. So maybe one of them or multiple of them with environmental factors might cause the squamous cell carcinoma. The pathogenesis in the Western countries, alcohol and smoking are the top most important causes. In other areas of the world, nutritional deficiencies and exposure to polycyclic hydrocarbons and nitrosamines and fungus-contaminated food might be also a cause. HPV infection is implemented in the high-risk regions, the human papilloma virus as part of an upper aerodigestive tract malignancies. The morphology, these tumors arise in the middle third of the esophagus in half of the cases, not like the adenocarcinoma, which is in the lower part of the esophagus. They present as polypoid or ulcerated or infiltrative masses causing wall thickening and narrowing of the lumen. So also they can present with difficulty in swallowing and dysphagia. They can invade the surrounding structures like the bronchus or mediastinum or pericardium or even the aorta. As you can see here, this is the mass in the mid-esophagus, bulging mass, and microscopically, if pre-invasive, the precursor lesion is squamous dysplasia and carcinoma in situ. Otherwise, if it is an invasive, we can call it well to moderately differentiated invasive squamous cell carcinoma. It can present sometimes as intramural tumor nodules away from the main tumor. So the tumor may be carried by the lymphatics to other parts of the by the rich lymphatic supply to other parts of the esophagus, even at the time of diagnosis, forming intramural tumor nodules. Lymph node metastasis can be seen according to the site of the tumor. If it is in the upper third, it will affect cervical lymph nodes. In the middle third, will go to mediastinal and paratracheal and tracheobronchial lymph nodes. In the lower third of the esophagus, it can go to gastric and celiac lymph node metastasis. As you can see here, this is the invasive squamous cell carcinoma composed of cells of squamous origin, similar to the normal lining of the esophagus. And as you can see here again, this is an invasive squamous cell carcinoma invading to the underlying tissue with associated fibrotic or desmoplastic response around them. The clinical features are dysphagia, difficulty swallowing, adenophagia, which is pain upon swallowing, obstruction, weight loss, and debilitation, impaired nutrition, tumor-associated cachexia. If the bleeding occurs from the tumor, ممكن is due to ulceration, it can happen, and the patient can be also present with sepsis. Aspiration via a tracheoesophageal or tracheobronchial fistula between the tumor and the trachea or the bronchus. These tumors have dismal prognosis. The 5-year survival is usually 10%. Usually they present late with advanced disease. And this is all regarding esophageal pathology. Thank you for listening.